Hello dear friends and colleagues. Today I'm going to show you mini-invasive reduction of two joint depression calcaneal fractures in one patient. This male 37 years old patient fell from height on his feet. The lateral X-ray views show negative Bellis angle in the right calcaneus and 0-degree Bellis angle in the left one. The CT scans show Sanders 2-type fracture of the right calcaneus and the Sanders 3-type fracture of the left one. The reduction had been carried out through the sinus tarsi approach. The first stage of reduction process of Sanders 2-type fracture was destruction device application. This device is based on two wires, one of which introduced into the distal tibial metaepiphysis and another into the calcaneal tuber. This device I had talked about in previous videos was developed in Ural Trauma and Orthopedic Institute by Glukhov and Chelnikov. Now you can see some space in the subtalar joint after distraction. This space facilitates the reduction of the articular fragments. The artificial hole is made in the posterior part of the calcaneal tuber and the elevator introduced in it. Despite direct visual control through the sinus tarsi approach, this closed reduction maneuver is often more effective than reduction through that approach. Anatomical position of both articular fragments had been achieved. Due to elastic resistance of the medial fragment, it had been provisionally fixed by two wires. Then, provisional wire fixation of articular fragments was carried out. Pre-drilling and spongeous subchondral screw installation took place. Take a look at the Bellis angle and sinus tarsi restoration. The definitive fixation had been achieved by calcaneal locking nail. Then all provisional fixation had been removed. You can see the articular line restoration in Brodin's views. We have checked this at different angles from 10 to 40 degrees. The end cap of the nail was installed to anchor it into the cortex. In the same way, the destruction device had been mounted on another foot. Traction was achieved and the artificial hole in calcaneal tuber was made. The reduction was made under direct visual control through the sinus tarsi approach, but we failed to achieve an anatomical reduction of all three fragments simultaneously. Thus, we were forced to change a plan. There were two ways to achieve anatomical reduction of all three fragments. The classic one is to evacuate all articular fragments except the medial one. Then you can connect them on the operation table and then return to the wound and apply to the medial fragment. In this clinical case, the fragments were large enough and it was impossible to evacuate them through our sinus tarsi approach. Instead of extracting the fragments, we moved them as far as it was possible toward the plantar surface. Then the medial fragment was elevated to the talar articular surface and fixed by wire. After intermediate fragment reduction, a Kirschner wire was introduced throughout intermediate and medial fragments to the medial side of the foot. I missed sustentaculum tali, so it was quite dangerous. The much safer variant is to put the wire through the sustentaculum tali not to disturb any anatomical structures. After the lateral fragment reduction, the wire was introduced in it from the medial side. After reduction was achieved, subchondral sponges screw and the calcaneal nail were installed in the same manner as on the right side. The articular surface was smooth in Brodin's view. The Bellis angle and the sinus tarsi were restored. The end cap was installed as well. Post-op X-ray views confirmed recovery of the height and contour of calcaneal bone. CT scans showed anatomical reduction of both articular facets in sagittal and coronal planes. That's all for this case, friends. I hope it was useful information for your practice. Please leave your comments below and share your own clinical cases. Have a good luck and see you next time.